Dr. Murray, are you there? Dr. Murray, are you there? Dr. Murray, we'll move on to questions now. Dr. Murray, can you hear me?
Tahun depan kita kena buat suggestion lah.
Kejap lah. Ini masalah
Dr.
dia.
Murray, Dr. Murray, are you there? Dear participant, please stay with us. Dr. Murray is having the connection problem. Probably we could wait a while to see whether Dr. Murray can connect back or not. Dear participants, due to technical issues, Dr. Murray will answer the question through the website. So with this, I would like to end this session and we'll move on to our next speaker. Dear participants, next we'll move on to our second speaker by Dr. Rosie Haniza Musa. In brief, Dr. Rosie Haniza Musa is currently the head of immunohematology at National Blood Centre in Kuala Lumpur. She has graduated from University of Putra, Malaysia in Biomedical Sciences, then obtained her Master's in Transfusion Science and PhD in Molecular Research Blood Group from University of Science Malaysia. She was appointed as subject matter expert in the field of immunohematology and mainly focused on immunohematology laboratory management, technical supervision, for serology and molecular testing, and also conducting National External Quality Program in blood banking. Now, let's welcome our second speaker, Dr. Rosie, to present her talk on the powerful tool for resolving antibody problems in transfusion lab practice. Over to you, Dr. Rosie.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning to all. So first of all, I would like to thank the organizing committee for inviting me to deliver this talk. So today I will deliver regarding powerful tools for resolving antibody problems in transfusion laboratory practice. So this is my outline of my presentation for today. Introduction, complex antibody investigation, choosing the appropriate tests, supplementary methods, case study, and summary. So as an introduction, first of all, we must know what is the immunohematology. The immunohematology is a medical study of blood groups, antigen, and antibodies. It also involves the immune response to transfusion of cellular elements, as example, red blood cell, platelet, and so on. It is also related with the clinical and serologic nature, which is essential. So, in transfusion laboratory, usually the testing we call as a pre-transfusion testing. The aim of this testing is to prevent hemolytic transfusion reaction by ensure appropriate blood type is given to patient and the optimal survival of red cells that we transfuse to the patient will be survive in the body. So it's very important for this testing, we should have a right sample from the right patient and request and issue the right product to the right patient. So the pre-transfusion testing include all these tests, ABO/RHD grouping and antibody screening. Both tests usually we call as a group scale and whole, or also known as a GSH. When the patient need the transfusion, only that we perform the cross-matching and also known as a GSM groups cross-match. If the antibody screening and positive and we get the incompatible cross-match, so we must further investigation by performing antibody identification. For today, I will more focusing on antibody identification. So, what is the antibody screening and antibody identification? The aim of this test is to detect clinical significant antibodies through indirect antiglobulin test, also known IAT, and also people also call as a antibody screening test. If the antibody is detected, we should identify the type of the antibody prior to cross-matching wherever possible. So when we know the antibody, we must supply the antigen negative blood to the patient, especially the clinical significant antibody cases. So, why do we need to identify? Is for transfusion purposes and a very important component of compatibility testing. It will identify any unexpected antibodies in the patient's serums that expose to the donor cells with the corresponding antigen. And it can be serious side effect, as example, hemolytic transfusion reaction. So, whenever the ward want to send antibody investigation to the lab, so the detail must be written on the request form for us to get a clue when we doing the antibody identification testing. The patient history is very important here. So the ward should write all these particular of the patient in order for us to get a clue for the testing. The patient history include the age, sex, race, diagnosis, history of transfusion, pregnancy, and medication. All these particular can provide a clue to us, especially in complex antibody. If we know the transfusion history, let's say the patient just transfused recently within 3 months, so the DCT result may be positive, and we also cannot doing the red cell phenotyping because the antigen not conclusive, because it may be a donor cells and not the patient cells, and interpretation of the result should be careful for cases recently transfused. In terms of technical variation, the tube we can use in 3 phases at room temperature, 37 and Hg phase, while the CAT technique only at Hg phase. Both are very cost effective, and for automation only CAT we can perform using the automation, while tube cannot. Okay, so both are manual serological techniques. Usually this is initial testing that provide first clue for us. Besides that, the knowledge of antigen and antibody characteristics are very important to recognize those clues. So we, from the experience can give a distinct advantage for us to identify the antibody. So we also must be patient for solving puzzles, especially the complicated case. So this is the flow chart based off antibody screening testing that we done in our lab. So all samples before transfusion, we must do the antibody screening test. So if we perform the antibody screening test, if the reaction showing no agglutination, means that there's no antibody. If we tested with the screening cell, it showed one or both of the cell agglutinated with the patient sera, means that this patient maybe have a antibody on the red cell. So we must proceed to antibody identification in order to know what is the antibody for this patient. So if we perform the antibody identification and the result showing no agglutination, means that confirm this antibody, this patient, no antibody detected on her or his cell. So when we detect a reaction consistent with the manufacturer's identification table, also known as antigram, so means that we can identify and conclude the antibody that we found from the test. This is a complicated cases. If the specific antibody not identified or reaction too weak to interpret accurately, so maybe we get an inconclusive result. So we must proceed with other supplementary tests in order to detect the antibody. As example, we use the second panel we have been treated with the enzyme. So antibody identification commonly used problem-solving techniques in our lab. Usually we will proceed with tube techniques. Usually the first line we use the gel kite. Then if we cannot get the result, we will proceed with the tube technique that we can be incubate at room temperature 37 AHG. Maybe because of we use the gel kite only can detect AHG phase antibody, not room temperature or 37. So after we proceed with the tube, we also proceed with the gel kite by using the papenized treated panel. Papenized is an example of enzyme techniques. So this panel maybe can detect any enhancement reaction, as example for RH kit Cal-Lewis antibody, and it also can inhibit some of the reaction of the antibodies, as example Duffy and MNS antigen. We also can proceed with the adsorption test, usually for the cases that have a mixture of antibodies. So to separate either auto or allo antibody, so we will do using the adsorption test. And also we also can use the we can perform the elution test. These cases usually that the antibody attached to the red cells. And last, we also do the antibody titration with cases with pan-agglutination reaction. So, what is the adsorption and elution? Adsorption and elution we perform after we get DAT positive results. DAT means direct antiglobulin test and also known as a direct UMS test. So if the DAT positive, we will continue doing the monospecific antibody. We want to know either the antibody is a type IgG or IgM or IgA or complementarity. So in our lab, we only use the gel cut which consists of IgG and complement. Okay. So for autoantibodies, this can be removed by autoadsorption techniques or alloadsorption techniques. Autoadsorption, we can use zigzag treated on cell. Alloadsorption, we can use the pair reagent cells. This I will be explained further later. Elution may be used to uncertain specificity of antibody coating on the red cell. Usually this case due to transfusion reaction or hemolytic disease of fetus and newborn. So what antibody neutralization is, we want to detect or inhibit or neutralize all nuisance antibodies to reveal any underlying allo antibodies. So then we have a phenotyping and genotyping methods. Phenotyping and genotyping method, we want to confirm either this allo or autoantibodies. Usually phenotyping are serological testing using antisera. There's a lot of antisera that we can buy from the manufacturer to confirm the antigen. But phenotyping cannot be performed if the patient has had a recent transfusion because it cannot differentiate whether this is a donor or patient cells. Then we go to the genotyping. Genotyping we can use if we cannot test the antigen using the phenotyping because of a recent transfusion or transfusion dependent patient, as example sickle cell and thalassemia. And also we can do for the patient that been treated with daratumumab drugs. Okay, the genotyping, the techniques are PCR, bioarray, and DNA sequencing. This is an example of the test. So, beside the method I explained before, we also can modify the cell or the serum of the samples. So, first, we can increase the serum to cell ratio in order to increase number of antibodies. Sometimes the antibody, the titer is very low. So, to increase the ratio, to increase the reaction, so we can increase the serum to cell ratio. At the same time, we also can increase the incubation time. So this can allow more time for antibody and antigen to sensitize. And also we can use the LIS solution, low ionic strength solution, to decreasing ionic cloud around red blood cell. We also can use PEG to decreasing water around the RBC. As I mentioned before, we also can treated the cell with the proteolytic enzyme, can enhance or remove certain antigen. In our case, usually we use the panel that has been treated with the pepenase to enhance or remove certain antigens. We also can use the polybrain to aggregate bringing antigen antibody closer. Okay, commonly used problem-solving techniques, usually for antibody identification to use for weak or equivocal reactions, suspected multiple antibodies, characterize unknown specificity. An adsorption study, we want to remove or separate antibodies. These are the study that be done by Shin et al. To show the red cell antibody showing different result between Lis Kumkat means that normal panel and enzyme Jalkat, which the panel have been treated with the enzyme. Usually they use the papain enzyme. So from here we can see using the normal panel, the unidentified non-specific antibody, they cannot specify the antibody. Then they proceed with the enzyme treated panel, it's showing the antibody. Most of the antibody is the RH, which showing that the enzyme can enhance the reaction of the RH and KIT antibody. So this second case only detect one of the antibody. As example, this patient, they detect only anti-big E using the normal panel. When they tested with the enzyme panel, little c come out. So this patient showing the anti-big E and anti-little c. So from this panel, enzyme treated, it can enhance the Rh antibody, and it shows the literacy came out from this panel. Like here, normal panel only identify the anti-JKA, but after they using the enzyme treated panel, it come out as a JKA and JKB antibody. So this is an example from our lab. By using the normal panel, which the reaction weaker 2+ and 1+. When we proceed with the enzyme panel, enzyme pepenase panel, the reaction becomes stronger, showing 4+ and 4+ is anti-BE. Okay. So now I will explain what is elution testing looks like. Elution usually we do whenever DAT is positive. Elution techniques mean that we free the antibodies from the sensitized red cell so that the antibodies can be identified. Usually, if the patient recently transfused, the antibody will be attached on the red cells. Okay, so in order to know what is the antibody that attached to the red cell, we must remove the antibody from the red cell. Then with this, we must use the elution technique. Elution technique can be, from the elution technique, we can remove the attached antibody to the, for the free antibody, go to the plasma. So after we did the elution test, the eluate, we can do the panel investigation and it can show the specific antibodies. So the eluate is a term used for the removed antibodies. Testing the eluate is useful in investigation of positive direct Coombs test. For example, cases like HDFN, transfusion reaction, or autoimmune diseases. The red cell can also be used after elution for red blood cell phenotyping is needed. So the eluate also can be run for red cell phenotyping. When tested with panel cells, the eluate usually remains reactive with all cells and the warm autoantibodies in present. Usually for the eluate are IgG type, warm autoantibody. So now we go to adsorption. Adsorption, we have two types, autoadsorption or allogenic adsorption. Also the short form we call as alloadsorption. For autoadsorption, these cases is not for the recent transfusion cases, and autoantibodies are removed using patient red blood cell. So alloantibodies can be identified. I will explain next slides. Alloadsorption usually for the case that recently transfused, and we use other cells with the patient's serums. So, adsorption procedure can be used to investigate underlying alloantibodies. ZZ or chloroquine bisphosphate can be used to dissociate IgG antibodies from the RBC. It may take several repeats. It depends how many antibodies the patient has. After the patient RBC are incubated, the adsorbed serum is tested with panel cell to identification the alloantibody if present. So autoadsorption is a technique that is most often useful in the workup of warm autoantibodies because it's at 37. Usually warm autoantibodies react very well against everyone's red blood cell and making antibody identification difficult because all of the cells on an antibody screening panel are incompatible with the patient serums. As a result, identifying an alloantibody can be very difficult since the autoantibody mask on the visibility of the alloantibodies. Means that the autoantibody masks the alloantibody. That's why we cannot detect the alloantibody for using the manual using the uh, using the simpler method. Okay, now I'll explain using the diagram. So imagine this patient has a warm autoantibody and also anti-BK, LO anti-BK. So the autoantibody was attached on the red cell, while the plasma having the floating the LO anti-BK. So to separate autoantibody and anti-BK, we must do the auto-adsorption method. So the RBC aspirated treated, we wash this sample, the red cell 3 times with PBS. Then we add equal of PEG with the patient red cell and also serum and plasma. And we mix well. Then we incubate for 15 minutes. We incubate at 15 minutes at 37 degrees. So after that, we spin and separate the supernatant and we do the antibody identification. So we will detect the anti-BK. Okay. So we go to alloadsorption. Alloadsorption, also called differential absorption, is a technique designed to remove certain antibodies from a patient's serum that contains multiple antibodies. This to identify what seem to be multiple unexpected antibodies is not include the ABO antibody, because ABO antibody is at room temperature. Z or chloroquine bisphosphate can be used to dissociate IgG antibodies from the RBC. Usually alloadsorption more to IgG types antibody. So this is an example. Let's say the patient has a anti-BS and also anti-little e. Both are allo antibody. So in order to confirm that this patient has these two antibody, so we must do the alloadsorption technique. So this sample we add with the S negative and little e positive cell, R1 and little s. So we incubate at 37 for 15 minutes. So the little e antibody, anti-little e, will go to the cell R1 little s cells. So will be attached to this cell. So remaining will left only LO anti-BS on the inside the plasma. So after that we centrifuge and we take the supernatant and we identification. It should show that LO anti-BS. So here we want to confirm the little anti-E, we will do the elution. So we remove the anti-E from the red cell and we eluate and we test with the antibody identification. It will show the anti-little e. So means it's confirmed this patient has two antibodies, anti-BS and also anti-little e. Okay, then we also can use the typing for blood group genes by using the traditional method, red cell phenotype, using the serological method. And also we can use the genotyping DNA-based analysis. So the test can be used using the PCR, real-time PCR sequencing and microarray. So this is techniques used in the red cell genotyping and the differentiate between the low throughput, medium throughput, or high throughput. For the low throughput, the techniques are PCR SFP, PCR RLFP, nested PCR, multiplex PCR. For the medium throughput, PCR sequencing, quantitative PCR, and high throughput microarrays, microarray and mini sequencing. For the application, for low throughput, usually we want to see common antigen like RH, Daffy, Cal, KIT, and others. For medium, we'll include the ABO and RHD variants. And for high throughput, usually for genotyping for multiple blood group patient, as example thalassemia, sickle cell, that we need the range of the antigen that this patient has. For the advantage, the low throughput is simple and easy and cost effective. Medium throughput, more sensitive, no post-PCR processing technique required. High throughput is very large scale donor typing for many antigens in single test automated. Like this is an example of the microarray. From the chip, we can get about 37 antigen blood group for the patient. Now we go to case study. First case referred to us, a 56 Malay man. He was multiple myeloma stage 3, diagnosed in 2009. He recently have post-stem cell transplant and also diabetic mellitus, and given daratumumab on 6 February 2017. From lab investigation, it showed that this patient has a blood group B RHD positive with direct Cumstes positive 2+. Then we proceed with monospecific, it's showing the IgG positive with 1+ and anti-complement very weak reaction plus minus. Then we also perform antibody screening and it show pan-agglutination with 1+ reactions. And we also perform patient phenotype. It shows that with R1RZ, TKNB pos, Daffy A pos, BNEG, M, S, and small and little k. So when we do the antibody identification using the gel method with normal panel, it shows the pan agglutination with 1+ with autocontrol 2+. And we proceed with the papenized panel, it also showing the same reaction, pan reaction with 2+, including the autocontrol. Because of the AT positive, we also perform elution test, and but is not showing any auto antibody, showing the negative results. So then we treated this cell with the DTT to eliminate the daratumumab drugs. So this is pattern untreated panel cell showing all the pan agglutination results. Then we treated this patient with the DTT. It showed AHG, all reactions are negative. Means that we have already eliminated the daratumumab drugs. In conclusion, it shows that this patient no antibody detected. As I mentioned, the conclusion, no antibody detected after panel cell was treated with DTT. Untreated panel cell shows pan agglutination made due to daratumumab drugs. Challenge with the current result. The clue to this case is the treatment with daratumumab. Dara is an IgG type 1K human monoclonal antibody targeting the cell surface protein CD38. This daratumumab is a clinical development for the treatment of multiple myeloma. Multiple myeloma cells have a high expression of CD38, making an interesting therapeutic target. However, CD38 is also expressed at low level on red blood cells. The anti-CD33 DARA found in the patient plasma or serum is what is causing the pan reactivity, and as it binds to CD38 on the test cells. Okay, due to the presence of CD38 on the test cell, DARA will interfere with the antibody screening, antibody identification, and as well as the cross-matching. If you not treated the cell with the DTT, the
我们不
cross-matching
知道哦。
get incompatible results.
就是我不要给他吃水，我自己也没有吃。
Identification positive. All are PET agglutination reactions. DARA movement bound to the test cell will thus mask detection potential antibodies
还有
that red cell antigens. How to resolve it? In order to eliminate the interference of anti-CD38 tests can be treated with trypsin or DTT. Reduction or elimination of reactive due to anti-CD38 is achieved by enzymatic digestion by trypsin or disulfide bond reduction by DTT. From the literature review showing that the TT treatment is better than the trypsin. Case study 2 that refer to us is to confirm the RHD blood group. She was female. This patient was female, Malay, 25 years old. There's no transfusion history before, and the diagnosis is for operation. So this is the lab investigation showing that BRHD, Curie RHD blood group, because the NTD showing the mixed field reaction. We also tested with other brand of NTD, 3 brands showing the same result, mixed field, and brand 4 showing the 2+ reaction. And DU test show all brands are 4+. Then we also perform direct test showing the positive 2+, and we proceed with monospecific showing the type of the antibody is IgG 3+. Then we do the elution test showing that auto-NTD detected. We also perform antibody screening and antibody identification, and it showed that NTD detected with titer 1/16. So to confirm this status, we proceed with the molecular testing. In our lab, we are using the Bajin kit for partial D type. So from here, we detected that this patient has a D variant type DFR. Okay, the molecular basis of the partial D phenotype is often RHD and RHCE hybrid alleles, in which parts of the RHD gene were substituted by the respective segment of the RHCE gene. It can arise from replacement of RHD exon by their RCE counterparts. I show in diagrams. So, as you know, on the RBC membrane, there's a antigen. This is the antigen D. Sometimes the RHD gene can be missing and replaced by the RHCE gene. So, missing the portion of this epitope, patient may develop the anti-D allo antibody because the antigen epitope are missing. So that's why they develop the anti-D. Okay, now we go to case study 3. A case of 52 years old Malay female hospitalized due to hemophagocytic lymphohistiocytosis, HLS, HP with 6.7, difficulty to get blood during pre-transfusion testing. That's why they referred us. From the lab investigation, it showed that this patient has ORHD positive blood group, direct test 1+, and with further investigation with the monospecific, it showed that IgG 1+, complement negative. We proceed with elution testing, shows that Curie anti-SDA specificity. Why we Curie anti-SDA specificity? Because from the antibody identification result, it shows that mixed field reaction in all column. This is the picture of the gel cut. For antibody screening, it shows mixed field reaction. We perform for plasma and serum to see any different. However, the reaction are still the same. And also, we proceed with the normal antibody identification by using the normal panel and also enzyme panel. And the result also same as the antibody screening between the plasma and serum. all showed the mixed field reactions. So then we proceed with the urine neutralization to confirm the anti-SDA. So we take 4 pool of individual. We collect urine from pool 4 individuals with unknown SDA types. Then we boil it for 10 minutes. We mix together the urine and we boil for 10 minutes. Then we spin and put and to get the separate the supernatant and sediment. Then also we need PBS pH 7.3. So now we proceed with the test. We label 3 tubes, different tubes, 3 different glass tube, label as 1, 2, 3. In tube 1, we put the patient's the urine and also patient serum. Tube 2, we put the PBS pH 7.3 with the patient serum. And the third one, we put the boiled urine with the PBS. And we incubate at room temperature for 30 minutes. After that, we add the test red cell 1% 50 microliter on the gel cut and add 25 microliter sample from these glass tubes. Okay. So from the result, it's showing that tube 1 neutralization occurs when antigen SDA in urine mixed with the serum, patient serum. Tube 2 neutralization cannot occur when PBS and serum mix because no antigen SDA in the PBS. Actually, this is a positive control. Negative control. And tube 3 neutralization cannot occur when urine and PBS mix because no anti-SDA in PBS. For the conclusion, is patient most probably anti-SDA detected. Now I explain what is anti-SDA is. This antibody is found in 1967 by McVie et al. And Breton et al. Was discovered new antibody and it called as a anti-SDA. SDA antigen is a high-frequency antigen found in about 91% of normal people. It is present in most body fluid as well as blood cell and renal tubule cells. In cord blood, SDA antigen is negative and antigen is detected from 10 weeks after birth. So characteristic of this antibody, it's usually IgM antibody and can give mixed free reaction was shown in gel column test that we get the same, neutralized by urine and it a low clinical significant antibodies. As a conclusion, investigation of complex serological problems must be carried out in a stepwise, informed way to ensure minimal possible delay in patient care. Knowledge of antigen and antibody characteristic is fundamental to recognize the clue when investigating complex immunohematology cases. Although there are many tools at our disposal, unfortunately, serologists skilled in manual serology techniques are becoming a rarity. This is because most of the lab nowadays using the automation method that all interpreted by the analyzer. So it is very important to embrace the molecular tools we know how at our disposal in the IH lab to achieve an optimal approach to solving problem cases. As for your information, the molecular tools is a complement for the serological methods because some of the serological method cannot detect any antigen, as example for recently transfused patient. So a molecular can be used to detect the antigen. So with that, I would like to acknowledge all my staff at the National Immunohematology Reference Lab and thank you for your kind attention.
Thank you, Dr. Rosie, for the great presentation. We'll move on to questions now. The first question is from IJN. What is the turnaround time for the red cell genotyping? Can you hear me, Dr. Rosie? Dr. Rosie? Dr. Rosie, can you hear me?
Yes, yes.
Okay, the first question is from IJN. What is the turnaround time for the red cell genotyping? Yes, I can hear you, but it's a bit poor connection, I think. Dr. Rosie, maybe you can turn off the video, please.
Hello.
Hello, yes. Sorry, can you hear me?
Hello.
Hello, yes, doctor. Shall we go for the questions now?
Okay, I have shifted money. I shifted to other. So money, I have changed to other PC. Can you hear
Okay.
me?
Yeah, it's very clear,
T80
doctor,
for
now.
red cell. Okay, T80 for red cell genotyping is 20 working days.
Okay, thank you, doctor. There's another question. It's the continuity from the first question. How long after transfusion phenotyping can be done?
Usually after for phenotyping, usually 3 weeks after 3 months, macam ada kita 3 months after transfusion.
Okay, doctor, we'll go for the following question. Is RBC genotyping routinely done in hospital in Malaysia or just in PDN? Usually, in which case need to be done?
Usually only PDN, for now, only PDN performing this test. So we perform for all the cases with thalassemia, cases, and also daratumumab patient with have treated with daratumumab patient that being treated lah. And also sometimes sickle cells that sometimes the visitor from Arabic visit Malaysia, suddenly they have a sickle cell crisis. So whenever we did the genotyping lah, it based of the test, the diagnosis for the patient. But mainly for thalassemia patient with means which have no baseline of phenotype lah.
Okay, doctor. So we'll go for another question. If you do not have the resources to perform antibody ID and we need the blood to be transfused and the cross-matching is compatible, what is your advice?
So we will usually we will cross-match in 3 phases, including from the immediate spin, 37, and also HG phase. Then we will run with control to ensure that the result is really compatible. Then we will be supply. Usually we follow the phenotype
for the patient phenotype, then we supply based of the phenotype patients. Only that we will proceed with the investigation.
Okay. Um, um, there's no more questions from the participants yet. Probably I could ask one question for you, Doctor. How to overcome if there's any interference that could mask the detection of any type of the antibody?
Sorry, can you repeat?
How to overcome if there is any factors that could mask the detection of any type of antibody?
So first of all, we will wash the cell first to make sure to eliminate all the fibrins. Then we will do the routine method starting with the grouping. Let's say the grouping is not tally for forward and reverse, maybe due to the cold antibody that can disturb the grouping. So we will further investigation, means that if the cold antibody interrupt the results, we will do the warm method, warm technique. We warm the cell and plasma for 37, and if the cold disturbance, the cold will remove and we can get the actual blood group. That's an example of the interference lah.
Okay, Doctor. So there's another question from Dr. Nur Najmi. Do you phenotype all patients or in certain scenario only?
So basically, we will phenotype for all newly diagnosed thalassemia, especially the multiple transfusion dependent thalassemia. We will phenotypes lah. But for other cases that if you want to if you detect the antibody, we will confirm with the phenotype. But for your information now, PDN already started to phenotype all the thalassemia patient. We have done in from the Likas Hospital. Then now we are focusing for the Ampang patients lah, especially the thalassemia.
Okay, Doctor. Since we still have another 3 more minutes plus, probably I can ask another question. Does the selection of testing method depends on the different characteristic of the antibodies?
No, because usually we will the basic testing in transfusion lab. Usually we do the my presentation stated that ABO grouping is must. Then we will continue to the antibody screening. Usually the first step we are using we are using the gel cut method. Then after the screening positive, only that we proceed with the antibody identification. Antibody identification, the first step we are using the gel cut. Is if the gel cut we cannot get the results, maybe due to the cold antibody. The cold antibody, the best method is we using the tube method. After we get the clue from the antibody screen, antibody identification, only that we will think what to do next step for these samples lah.
Okay, Doctor. Just the last question from me, because there's no any other questions from the participants, since we have another 2 more minutes. I'm just wondering whether we can use the cord blood specimens for the pre-transfusion testing.
Can only for the ABO grouping and direct Coombs test. If for antibody screening and also cross match, we must use the mother sample. Because baby they have no antibody. The development of antibody after 4 months. So like blood grouping, we only do the forward groupings, mean that we detect only the antigen, not the antibody.
Okay, Doctor. Last but not least, I just want to ask one more last question. What is the minimum pre-transfusion testing requirements for autologous donation?
Is actually autologous and also the donor normal donation are the same. We will do the autologous donation. We do as a routine, as a ABO grouping, and also then for if then we will cross match with the patient.
Okay. There's another question from the participant. Do PDN also do other molecular testing?
What do you mean by other molecular typing?
I suppose they're asking, other than the specified tests that you have mentioned just now, is there any other
Yes.
molecular testing is being done?
Yeah, in my lab we perform red cell red cell genotyping, normal and also extended. Extended means we also include all the rare antigen, as example Dombrok, Diego, and so on. And also we also do perform the RH variant genotyping to detect any weak D or partial D type. And also we do the RHD zygosity for the baby. And also, we also for ABO variants, we want to know if any subgroup of the patient has or donor has. And also, we also in our lab platelet genotyping. But platelet genotyping is based on our diagnosis, usually an NAIT patient.
Okay, sure, Doctor. Doctor, there's a few more questions. Due to time constraint, probably you could answer the participants in the chat box. So with that, I would like to thank you for answering those questions and for the interesting presentation. So is there anything else you would like to say before the wrap up?
Okay, before the end, I would like to thank the organizing committee to invite me to deliver this talk. Thank you, everyone, and enjoy for the next workshop. Thank you.
Okay, thank you, Doctor.